Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hi, this is Danielle Eytan.
And this is Antonius Varelas.
Coming from NYU Langone Health. Today we're going to be talking about our paper, Reanimation of the Lower Lip with Anterior Belly of Digastric Transfer, a Systematic Review. In this study, we investigated the question, among patients with flaccid facial paralysis of the lower lip depressors, do those treated with the anterior belly of digastric transfer for dynamic lower lip reanimation demonstrate improvement in patient satisfaction and objective symmetry measures, as measured by a variety of reported metrics? We know that facial nerve paralysis has a profound impact on both the functional and emotional well-being of patients. The duration of the paralysis and mechanism of injury often guide initial pharmacologic and subsequent surgical interventions. Surgical options can include interposition grafting, nerve transfers, muscle transposition, and free muscle transfer. While redundancy in the muscular innervation exists in the midface branches of the facial nerve, the frontal branch and the marginal mandibular branch exhibit the least amount of redundancy and thus are at most risk of lasting disfigurement after injury. Although we now have a number of successful techniques for dynamic reanimation of the paralyzed midface, isolated lower lip depressor weakness or paralysis remains a challenging reconstructive entity. The anterior belly of digastric transfer has been described since 1967 by Edgerton. This was first described for isolated marginal mandibular nerve paralysis, and this was eventually modified by Conley and Baker in 1982. Unlike the posterior belly, which is innervated by the facial nerve, the anterior belly of the digastric is innervated by the nerve to the mylohyoid, a mandibular branch of the trigeminal nerve, and allows for successful muscle transposition. However, the literature is sparse in describing long-term outcomes from this technique. In our search for other options for our patients, we became interested in evaluating the experience with anterior belly of digastric transfer.
In this study, 2 independent reviewers performed a comprehensive literature search of 3 different databases. Publication bias was assessed in accordance with the Robbins criteria, which is based on the Cochrane risk of bias tools. Now, the original technique, as described by Egerton, included a submental incision made to access the anterior belly of digastric. The neurovascular pedicle is maintained, and the muscle is mobilized by dividing the digastric tendon at its most posterior position to maximize available length, with a portion of the posterior belly sometimes included. The tendon is then split into 2, and a supraperiosteal plane is developed to avoid injury to the mental nerve and establish a submental tunnel. The slits of the tendon are then sutured into the orbicularis oris muscle at or below the vermilion border. Oftentimes, an additional incision is necessary along the lower lip to facilitate positioning and suturing the tendons. Now, variations in the choices of innervation for the anterior belly of digastric muscle transfer exist as well. Single-stage reanimation via the nerve to the mylohyoid, a branch of the mandibular division of the trigeminal nerve, offers a single procedure but without spontaneous activation. Patients must learn to activate the anterior belly of digastric muscle through smile retraining with a physical therapist. The most popular alternative method of innervation is a 2-stage cross-face nerve graft. While it requires 2 separate procedures and a delay in muscle positioning, it offers patients a better chance at a spontaneous smile. In that procedure, the first stage comprises of identifying branches of the contralateral lower lip depressors from the marginal mandibular and cervical divisions. There typically exists about 3 to 4 redundant branches, and one is chosen in order to coap to the cross-face nerve graft that's brought up from the sural. Once adequate axonal regeneration has been identified via the Tinel test, the second stage was performed, which consisted of the anterior belly of digastric transfer and the sural cross-face nerve graft coaptation to the recipient nerve to the mylohyoid. In our literature search, a total of 115 potentially relevant studies were screened, with 9 meeting both inclusion and exclusion criteria, comprising 164 patients with an average age of 37. Most patients had hemiparalysis or more extensive paralysis, and 36% had isolated lower lip paralysis. The leading cause of paralysis was iatrogenic at about 48%. These cases were either necessary or inadvertent, with parotidectomies and vestibular schwannoma resections being the most common. This was followed by congenital paralysis at 32%, with idiopathic, Bell's palsy, and trauma tailing behind. Regarding staging, 52% were performed in one stage with native myelohyoid innervation, while 46% were done in two stages with a cross-facial nerve graft. Denervation time for patients that did not undergo immediate transfer averaged about 16 months, with a range from 1 month to even 51 years. Transfer timing varied as well, with 36% being done immediately at the time of an ablative procedure and 64% being done in a delayed fashion after a conversation with the patient. Many different outcome measures were used to determine the efficacy of such a transfer, but it was difficult to compare between all of them as they had different criteria for their scales. However, a number of studies reported overall satisfaction and described them between the surgeon and the patient. The overall satisfaction with the procedure was 92%, with about 90% patient satisfaction and 94% surgeon satisfaction. The overall reported complication rate was low at 12%, with the most common complication being a poor cosmetic outcome requiring revision. Now, of course, there's limitations to any study, and systematic reviews are no different. The data is typically retrospected and aggregated across different authors and different methods. And the outcome measures in these cases, as is common for facial reanimation literature, often vary from method to method. But overall, this does seem to be an effective method of approaching the lower lip.
The systematic review of 9 studies in 164 patients demonstrated that the anterior belly of digastric muscle transfer can serve as a useful and safe reanimation technique in either a one-stage or two-stage approach. Lower lip dynamic reanimation is a challenging dilemma for reconstructive surgeons. While we often address this by silencing the contralateral side, dynamic reanimation options for the paralyzed lower lip can provide patients with a more functional smile and lower lip depression. Surgeons should consider this option for use either in isolated marginal mandibular paralysis or together with alternative reanimation methods in a comprehensive approach.
We'd like to thank the authors for presenting their work and thank you for listening. Catch you on the next one.